Welcome to today's webinar, a psoriatic arthritis research update. My name is Bev Bromfield, Patient Education Programs Manager here at MPF. It's my pleasure to introduce you to our guest moderator for today's webinar, Avery Merten. Avery is a 4-year medical student who was born and raised in Northern Kentucky. She was diagnosed with psoriasis at 8 years old and psoriatic arthritis at age 21. Her parents became part of MPF when she was diagnosed, and Avery joined as a one-to-one volunteer mentor at age 24. She has a passion for helping others work through and cope with their diagnoses. She has also been interviewed for People magazine, where she shared her story about living with psoriatic disease. Thank you, Avery, for being here today and for all you do to help MPF.
Alrighty, now I'd like to take a moment to acknowledge and thank Amgen, UCB, Johnson & Johnson, and Bristol Myers Squibb for their support of today's webinar. Thank you. Before we start, a few words about what the National Psoriasis Foundation does. At the heart of all we do is our mission to drive efforts to cure psoriatic disease and improve the lives of those affected. We accomplish our mission by funding research with over $30 million awarded in grants and fellowships, collaborative and transformational research initiatives. The NPF also offers education for those living with psoriatic disease and encourages all to become involved with our mission. Learn more about our research, education, and how you can become involved by viewing the links listed on this slide. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, a psoriatic arthritis research update. Now I'd like to introduce you to our speaker, Dr. Christopher Ritchlin. Dr. Ritchlin is a professor of medicine in the Division of Allergy, Immunology, and Rheumatology at the University of Rochester Medical Center. His primary research interest is in understanding the mechanisms that trigger pathologic bone resorption and new bone formation in psoriatic arthritis and rheumatoid arthritis. As the director of the Clinical Immunology Research Unit, Dr. Ritchlin is the principal investigator on several clinical trials testing the efficacy of TNF inhibitors and other novel biologic molecules such as IL-23, IL-17AF, and others in the treatment of psoriatic arthritis, rheumatoid arthritis, and ankylosing spondylitis, as well as how such treatments can alter the bone remodeling process that occurs with such diseases. He is a founding member of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, which is a network among different medical disciplines that seeks to bring a greater understanding of the research, diagnosis, and treatment of psoriatic diseases. Dr. Ritchlin is a member of the MPF's Scientific Advisory Committee and is a past member of the MPF Medical Board. He also served as the co-chair of the MPF COVID-19 Task Force, identifying guidelines for use of the mRNA vaccines and use of biologics. As a result of his dedication to research advancements and education, Dr. Ritchlin received a Lifetime Achievement Award from the MPF. He is simply one of the world's foremost rheumatologists, and I am honored to welcome Dr. Christopher Ritchlin for today's webinar. Welcome, Dr. Ritchlin.
Thank you, Avery and Bev. Appreciate the introduction. And I want to talk about some elements of psoriatic arthritis, particularly in regards to research and current therapies. I have the following financial relationships to disclose, including serving as a consultant for multiple companies and carrying out research. In addition to the research support you're seeing here, I also recently received a grant from Novartis Pharmaceuticals. So today what I'd like to talk about is the latest research in psoriatic arthritis addressing 3 points. One is the diagnosis and management of psoriatic arthritis, the pathways that lead to a greater understanding of why PSA develops, and then current treatments and therapies in the pipeline. So let's start with diagnosis and management. So one of the really challenging elements in the diagnosis and management of psoriatic arthritis and psoriasis are their complexity and heterogeneity. So complexity meaning several components with nonlinear interactions, and heterogeneity that not all the components are present in all patients. And so this has been a challenge and continues to be, but I think as we move to more of a precision-based approach, that we'll be able to use these kinds of features to the advantage of the patient. And I'll get into that later. So we know that there are multiple domains of involvement in psoriatic arthritis as shown on this slide. Certainly most patients have peripheral arthritis and skin and nail disease, but one can also have disease in the spine, anywhere in the spine, so-called axial disease. Dactylitis, which is swelling of a digit or a toe. It's a flexor tenosynovitis, so the flexor tendons are inflamed. And then enthesitis, which is inflammation at where joint capsules, tendons, or ligaments attach to bone. For example, Achilles tendon, the plantar fascia, or the elbows, as well as other sites. So patients often present with more than one of these domains involved, which adds to the complexity. And patients often present with more than one domain. This is work from Alexis Ogdi at the University of Pennsylvania, showing that a significant number of patients have 2 or more domains of involvement, some even 3 and 4. So when thinking about how to treat a patient and diagnose them, the clinician really needs to consider all of these domains, which means a careful history, as well as a physical exam that looks at the skin, the joints, the peripheral joints, the spine, the digits, and also takes into account other factors, which I'll get into shortly. So here you see the complexity and heterogeneity of this disease, which is quite important when you're thinking about what a patient, whether or not they have psoriatic arthritis. So this is something we prepared for a grant recently submitted, and showing you the different domains and then the associations with each of these domains in terms of genetics, as well as other elements and cytokines, which are small molecules that drive inflammation, and then the different cell populations at the individual sites that are affected by this disease. And as you can see, there are some differences among the different domains, and it's these differences that we are really trying to understand in terms of the pathways that are driving peripheral arthritis that may be overlapping or different from those that are in axial disease, psoriasis, et cetera. And I'm going to show you how we're proposing to do that and actually doing it now. So this slide illustrates the clinical spectrum of psoriatic arthritis, beginning with the idea of both systemic and local factors that can lead to the development of PSA, including genes, environmental impacts such as infections, smoking, adipose tissue or obesity is a factor we know involved in the pathway to PSA and psoriasis, as well as biomechanical stress on a tissue, or such as an injury induced by trauma. And then we're beginning to gain insights into how abnormalities in the gut, so-called dysbiosis, may be very much linked to the onset and progression of both psoriasis and PSA. The spectrum of disease is shown in the center, and I've already emphasized that, although I've not mentioned uveitis, which is inflammation in the anterior portion of the eye, which is seen in about 5 to 8% of patients with psoriatic arthritis, and then inflammatory bowel disease, which also tends to co-occur in a minority of patients with PSA. And then there are a number of comorbidities which can influence how a patient perceives their disease and also how they respond to therapies. And these include depression, non-alcoholic fatty liver disease, diabetes, obesity, atherosclerosis, just to name some of them. So when working with a patient with psoriasis or PSA, one has to take into account all of these elements in order to properly diagnose and manage the condition. So there is a treatable trait strategy which was developed by pulmonologists and is outlined in this slide. And that is, how do you, when you meet a new patient who appears to have PSA, how do you make the diagnosis and how do you think about them from a comprehensive perspective? So the first question we ask is this really arthritis? Is this that they have joint involvement? Do they have spine involvement? And in order to do that, we need to have a very thorough history and physical exam, blood work, and imaging, which can include ultrasound, sometimes radiographs, and in some cases, other imaging such as technetium bone scans or MRI. And the next thing we do is trying to investigate the endotypes. And by endotypes, I mean the pathogenesis. So what are the elements in an individual patient that may tell us what subtype of psoriatic arthritis might they have, that might give us clues as to the type of therapy that are most likely to respond to. And we're not there yet, but I'm just showing you the kinds of data we're looking at now in our studies to be able to identify an individual's endotype. And these include genetics, epigenetics. These are changes that can occur in genes because of environmental exposures, toxins, or other kinds of factors, even climate. Immune pathways that may be driving disease in an individual tissue, metabolites, so what are they eating, what's their diet, are they obese or not, because this influences the activity of the disease. And then more recently, work that's being carried out in psoriatic disease is trying to understand the influence of the microbiome, both on the skin and in the gut. So the next thing is to address extra-articular traits in an individual, which include, as I've already alluded to, diabetes, uveitis, colitis, depression, anxiety, and something called centralized pain, sometimes also referred to as fibromyalgia, which can occur when patients develop significant discomfort to the point that it's interfering with their sleep patterns and they're unable to reach the deeper stages of sleep. And if that goes on for a period of time, they develop diffuse soft tissue pain, which can often be seen in co-occurrence with arthritis, but also can be seen as a separate entity and requires different kinds of therapeutic approaches. And then other treatable and behavior and lifestyle risk factors such as smoking, exercise, food choice, anxiety, depression, symptom perception, adherence to treatment, social support from family and friends, and also work stress. So these are the kinds of elements one has to think about in approaching a patient with psoriasis or PSA. So let's talk now about the pathways that lead to a greater understanding of why PSA develops. So this is a complicated slide, but I'll break it down for you. So this is looking at the mechanistic pathways that underlie psoriatic arthritis. So on the outside of the circle, we have psoriatic skin inflammation. We call dysbiosis, which is inflammation that's present in the gut, in the small and large intestine, which can lead to the release of immune cells that go from the gut to the joint or the skin. Metabolistic elements and also obesity can influence the immune system. And then what we call mechanoinflammation, which is biomechanical stress, which is present in the extremities such as the foot or the elbow or other areas that can lead to enthesitis. So the inducers, these cytokines and molecules are induced by these four different areas, include interleukin 23, which is released by different cells called monocytes. And interleukin 23 is sort of the executive, if you will, that then can influence the development of other immune cells that are shown in the second circle, which are the IL-17 releasing cells. And then on the inner circle are those cells that actually are acted on by IL-23 and IL-17. And these include macrophages and neutrophils that can release additional cytokines besides IL-23 and IL-17, particularly tumor necrosis factor alpha or TNF. Now, there are a number of different cell types that play a role in the different tissues of psoriasis and psoriatic arthritis. They include cells of the immune system, T cells in particular, and also cells that we call the innate immune system that don't have specific receptors, but are activated by signals that are released by damaged tissues. And these immune cells that have specific receptors and those that are innate work together to dramatically increase inflammation and can result in the phenotype that we see of psoriasis or psoriatic arthritis. So here I'm showing you the types of pathways that are present in the skin the joints, and the entheses. Dominant among these pathways in the skin is IL-23 and IL-17, with a lesser role for tumor necrosis factor alpha. In the joints, we also see IL-23 and IL-17 pathways, but very major role for TNF. It's somewhat different than the skin. And the entheses is a combination of TNF, IL-23, 17, and a prostaglandin called PGE2. But this is a very superficial understanding because we really have not carefully dissected pathways in the individual tissues. For example, what's going on in the skin that might differ from the joints, that might differ from the enthesis, and I'm going to show you how we're doing that now. So we have developed, with support from the National Psoriasis Foundation, a humanized mouse model of PSA and psoriasis. This is a mouse that does not have its own immune system. It lacks B cells and T cells, which are critical for an immune response. But they've been implanted with genes that can allow for the engraftment of human tissue. And you can study the tissue in this mouse model. What we did in our laboratory, Luz Garcia Hernandez, a senior scientist, developed this approach, is to inject these mice with cells and sera from patients with psoriatic arthritis and psoriasis and healthy controls. And what we found, which was really quite amazing, was that the types of psoriatic arthritis or psoriasis that the patient had, from whom we obtained the blood and the serum, would actually be reproduced in the mouse. This was unexpected and quite dramatic. So I'm showing you an example here in A of a mouse that was injected with healthy control, cells and sera on the left, the middle with cells and sera from a patient with PSO or psoriasis, and in the right, injected with cells and sera of a patient with PSA. And what you see is that the PSA patient, the paws are very swollen compared to the healthy control in the psoriasis. And then we also had a patient that had dactylitis, which is a diffuse swelling. And again, if you look over to the right in B, the mouse that was injected with the patient that had dactylitis developed dactylitis. You can see the cells that are infiltrating the paw of the mouse. Again, these are all human cells that were derived from the patient. And then down below in D, we can see that there is evidence of inflammation in the joint, as you see in C, that we don't see in B or A, which are the controls. And moreover, we can recreate, if there's damage to the joint in the patient, it'll be recreated in the mouse. And then up in C, the patients that have spinal involvement with psoriatic arthritis, this is also recreated on the left in the mouse. And we can actually block it with different cytokine blockers, such as IL-32, as shown on the right. We also can recreate psoriasis in this mouse model very dramatically. So we're hoping now we can pull these cells then out of the skin and out of the joints and analyze the pathways that are present in these different sites and gain more understanding into the individual genes, cells, pathways that are driving the disease in the skin, the joints, the enthesis, and in the spine. So these are new discoveries. This paper has been accepted for publication, and we're very excited to collaborate and continue using this model to understand the key elements, key pathways that drive this disease. So other work, additional work funded in our laboratory by the NPF is shown here, and that is, are there markers in the skin that can give us insights into what's happening in the joints? So here we're looking at a molecule called rank ligand. Rank ligand drives joint destruction and is a key cytokine involved in that process. And here we're showing that when you look in the skin of patients with psoriasis or psoriatic arthritis with or without joint damage, we see that there's no rank ligand expression in psoriasis. We don't see rank ligand expressed in the middle in PSA patient without joint damage. And on the right, in a patient with PSA and joint damage, marked elevation and shown in the red down below of rank ligand in the epidermis, which was unexpected compared to the other two samples. Down below, we're looking again at other molecules that are upregulated by the keratinocytes, which are the skin cells, and we're seeing them we're stimulating them with different cytokines and showing you that it's the keratinocytes or the skin cells that show marked response of activation of rank ligand and other cytokines compared to peripheral blood monocytes. So what this is telling us is that we can gain insights into the joints by looking at the skin. And this is really exciting. And additional work is going forward to understand how we can take this into the clinic. Now, we also study bone remodeling, as you heard from Avery at the beginning. Unlike RA, which is shown on the left, which tends to be a disease which is symmetric across the joints and has erosions on both sides that are generally pretty similar. On the right, as a patient with PSA, you can see it's very asymmetric. On the left, there's certainly arthritis in the hand, but nowhere as severe as in the right. I point you to the metacarpophalangeal joints that are the first joints you see beyond the wrist, and see marked joint space narrowing and erosions, which is really quite extensive. So one of the features of psoriatic arthritis is it can be very, very destructive, but it can also lead to new bone formation, which is shown here. These are patients of mine who have bony fusion. So here's a patient in the upper left-hand corner where the fourth digits are fused in flexion. The bone is fused across the joint. You can see on the left lower corner, this is a patient that has what we call an enthesophyte, which is a bony formation going along the plantar fascia. And then on the right hand, in the longitudinal view, is a spinal film of a patient with PSA. And you can see over on the right side of the vertebra, these bony, what we call syndesmophytes, which are these bony masses that come off the side of the vertebra and are really only seen in psoriatic arthritis. So what's unique about this disease, it can be characterized by both bone erosion and new bone formation. They often occur at different sites in the individual, and they are both driven, we believe, by inflammation. So how are we taking to address this disease mechanisms in humans outside of our mouse model? Well, we have a team of investigators that are being funded by the FNIH and the NIH, which is the AMP-AIM program, Accelerated Medicine Partnerships, Autoimmune and Immune-Mediated Diseases. And there are 4 different diseases being studied: lupus, Sjogren's syndrome, rheumatoid arthritis, and then our team is the psoriasis and psoriatic arthritis team. You can see the lead investigators across the top. Our team is called the ELLIPSE team. And we are a group of dermatologists and rheumatologists, as well as rheumatologists that do synovial biopsies, who are working together to obtain tissues from patients with psoriasis and PSA in order to better understand what are the disease mechanisms driving the disease, and to break down this complexity and heterogeneity. And below, you can see the various investigators at institutions around the country. We are now collaborating with 9 institutions that are shown below. And not shown here is Hospital for Special Surgery in New York, which was recently added to our team. We also have 4 patient research partners as shown there. So the kind of analyses we're doing are really cutting edge, and these include single cell RNA-seq. We're able to see what an individual cell, all the genes that are producing, and then to work backwards to figure out what kind of cell that is. We're doing spatial transcriptomics, where we can take a section of synovium or skin, and then using some very advanced molecular techniques, find out what types of cells these are and how they're interacting with other cells. We can look at the different proteins in the sera with proteomics, and then looking at the genetics and epigenetics using a variety of very cutting edge techniques, ATAC-seq, ChIP-seq, et cetera. So this is really an amazing consortium of both pharmaceutical companies, academic centers, the FNIH, the National Psoriasis Foundation, the NIH, all coming together to address these fundamental questions of mechanisms in psoriasis and psoriatic arthritis. So these are the key questions we're addressing. What are the key immune and effector cells in the skin, joints, and entheses that promote the specific phenotypes or the presentations that we see in the office? 2, can we define the cellular and molecular signatures of both remission and treatment response in longitudinal psoriasis and PSA patients? And then lastly, how can we characterize the host, environmental, and other factors that contribute from this transition from psoriasis to PSA, knowing that about 30% of patients with psoriasis will develop PSA, but we don't know who those 30% are. And we're trying to develop biomarkers to tell us that, so that we may be able to treat them aggressively before the onset of arthritis to either prevent it or ameliorate the severity. These are the cohorts we're studying. So on the left is psoriasis, on the right, psoriatic arthritis. We're looking at patients with psoriasis with a variety of different presentations of the disease. And the same thing with psoriatic arthritis is shown here. That's cohort 1. And these are patients that are either treatment naive or have not been exposed to biologics. Once they're brought into cohort 1, we follow the psoriatic and psoriasis patients longitudinally, and we're looking for responses or non-response, and then re-examining tissues in those patients who are not responding. And then the third group are patients with psoriasis who are following for the development of PSA and trying to determine what are the various molecular and cellular elements as signatures that can push development of the disease. We have additional studies. We're looking at uveitis phenotypes in patients with psoriasis and PSA. We also have a pain supplement that we are trying to understand the different pain syndromes that patients experience with both psoriasis and psoriatic arthritis, and looking at the different types of pain that you can see, including neuropathic pain, nociceptive pain, pain that's being driven independent of the involvement of the skin or the joints, either from anxiety, depression, or from lack of sleep. So these are two other areas that we're exploring now, and we're very excited about the ability to do so. So let's talk about current treatments and therapies in the pipeline for PSA. So here's our treatment toolbox. We have 14 agents that are approved for the treatment of psoriatic arthritis, which is really quite amazing. When I started studying this disease in 1991, nothing was approved for psoriatic arthritis. And it was thought that the treatment of PSA is similar to RA. Well, we now know that although there's some overlap in therapies, many of them are very discrete, and many treatments that are effective for RA are not effective for PSA and vice versa. So on the upper left-hand corner in green, you're seeing what we call the DMARDs, disease-modifying anti-rheumatic drugs, the TNF inhibitors in light blue, and then adjunctive therapies, which are incredibly important in the center. And then other therapies that are shown here in different colors, which you're probably very aware of: IL-12/23 inhibitors, the PGE4 inhibitor apremilast, the anti-IL-17 agents, abatacept, which interacts with T cells and antigen-presenting cells, the JAK inhibitors, UPA and TOFA, and then the IL-23 inhibitors, guselkumab and risankizumab. There are a number of agents that are in development. I'll be talking to you about those shortly. But we have a lot of agents we can use, which is great, so that if patients do have a non-response to a particular drug or inadequate response, they lose response, we do have a lot of alternative therapies to offer our patients, which is exciting. So I want to talk briefly about a very important cell population that I think is very important in psoriasis and psoriatic arthritis. And these are called T-resident memory cells, or TRMs. These have particular markers, so we can find them in this tissue or with various antibodies. They provide rapid on-site response and reactivation to any kind of pathogen or trauma. The highest number at sites of primary activation. So if you give someone inoculation with some type of vaccine, the T-resident memory cells will be highest at where the injection was, but then they spread out over the entire skin or other tissue. They're long-lived in the tissue. They don't recirculate a lot, but there's evidence that they actually do have the ability to recirculate, which is interesting. And they're specific for an antigen. So in the skin, they respond to strep or candida or herpes virus, in the gut to salmonella or rotavirus, and in the lung to influenza A and mycoplasma. So they are there to protect, but sometimes they can become pathogenic and release cytokines that are very important in the diseases that we're interested in, including IL-17 And it may be, as I'm going to show you, that interleukin 23 is critical to their long-term survival. And this is important because it's thought that these T-resident memory cells are the cells that may be largely behind flare. So when a patient is doing well with a drug, then all of a sudden they flare and don't respond. There's some evidence that these T-resident memory cells, particularly in psoriasis, are those that are activated, and they've stayed in the tissue despite treatment with a specific medication, such as an anti-TNF. So in this study, they looked at patients who had been treated with an anti-IL-23 agent, guselkumab, with psoriasis, and they compared the T-resident memory cells in the skin in patients who received an IL-23 inhibitor, guselkumab, versus an IL-17 inhibitor. And what you see on the left in A is that these are T-resident memory cells. Those are the markers for those cells. And you can see that over a period of baseline to 24 weeks, the number of these cells in the setting of IL-23 blockade go down significantly, which is not seen in the patients that received an IL-17A inhibitor. There's other studies now that are showing similar findings with IL-23 blockade. And the reason that this is important is that it may be that this type of therapy could lead to long-lived responses that could be quite dramatic. I'm not saying cure here at all, but the idea that a key pathogenic cell is going down in the tissue with a specific intervention is very exciting. And additional studies are underway to both confirm these findings and also to determine longer-term outcomes in patients who have a decline in the cell population. So another approach we are taking is looking at combination therapy in psoriatic arthritis, combination biologics. So one can imagine doing this in many different ways, starting out with one biologic, and let's say their joints are doing well, but their skin flares, adding a second biologic that addresses the skin, taking patients with very severe early disease and using combination biologics right off the bat, cycling biologics, so trying one, and then if that's not working, stopping and trying another one, and moving back and forth has been done as well. So we don't have any insight right now as to what the most effective strategy might be, but we do have a study that's just come to conclusion that might give us some knowledge about combination biologics. This study is based on findings in a disease called ulcerative colitis, where they use combination biologics. This is a form of inflammatory bowel disease. They used an anti-TNF golimumab plus an anti-IL-23 guselkumab. They looked at both of these individually, and then they looked at the combination. And what you're seeing here these are outcome measures that are looked at in ulcerative colitis. They're not ones we use in psoriasis or psoriatic arthritis, but you can see here that the combination of the IL-23 and anti-TNF was more effective than either of them alone. And furthermore, if you look over to the right, what you're seeing here are the genes that are upregulated in ulcerative colitis, the inflammatory genes in red, and the genes that are healing genes, if you will, in blue. And when patients before treatment, if you look at their inflamed bowel, they have a lot of genes that are upregulated, that are inflammatory, and downregulated, that are protective. But when you look down in the middle, you see those patients that received golimumab or guselkumab, the TNF and the IL-23 monotherapies, you see there's a really decline in the inflammatory genes and an increase in the healing genes. But look at the number of differences in the combo. A 8 to 10-fold difference in the decline in inflammatory genes and the increase in healing genes. So the idea here that a combination can give you a much more dramatic effect is illustrated in this study. So in order to try and see whether this may be the case in psoriatic arthritis, we have just completed the affinity study, very similar design to the Vegas study I just showed you in ulcerative colitis. We compared the combination of guselkumab and golimumab to just the golimumab alone. And the primary outcome measure is minimal disease activity, which looks at all 7 domains. This study has completed enrollment and they're now analyzing the data, and we should be seeing the results of this by the end of the summer. Very exciting as an alternative approach in patients that either have severe disease that are non-responding to current treatment. So therapies in the pipeline are shown here. Those that inhibit IL-17, bimekizumab is one that inhibits not only IL-17A, which is what we see with Taltz and Cosentyx, but it inhibits also another isoform or a form of IL-17 called F, and that's bimekizumab, approved for psoriasis in this country, awaiting for approval for psoriatic arthritis, but it's very effective. Sonelokimab is a very small nanobody. It's about 1/10 of the size of bimekizumab. It also binds to IL-17A and F, and that's in phase 2 trials. And izokibep is another small nanobody. These are both injectable that has IL-17A on both ends and is being studied in psoriatic arthritis. There's a number of drugs that inhibit IL-23 that are in development, other than those that I've shown you already. Tildrakizumab has been approved for psoriasis and inflammatory bowel disease, and I anticipate approval for PSA. Deucravacitinib is an oral JAK1 TYK2 inhibitor, as is brepocitinib, and these are deucravacitinib is approved for psoriasis and is completed phase 3 trials for psoriatic arthritis. Obviously, the advantage here is that it's oral, and I anticipate that will be approved for psoriatic arthritis as well. The J&J 772 is really exciting as well. This is an IL-23 inhibitor. So unlike the other IL-23 inhibitors, which are subcutaneous, this can be taken by mouth. It's a small molecule that inhibits IL-23. And we just saw phase 2 data on psoriasis with this drug, and it's very effective with a low side effect profile. So more to come on that, as yet to be examined in PSA. And so lastly, we're trying to understand the events that are driving the development of psoriatic arthritis in psoriasis patients. We have the PAMPA study, which is underway, and this is taking patients who have psoriasis and no joint pain, but who have abnormal musculoskeletal ultrasound, randomizing them to receive guselkumab, the IL-23 inhibitor, or placebo. And then there's a third standard of care group where patients with psoriasis who have the abnormal ultrasound but elect not to go on a systemic therapy. And we're following these patients long-term for the development of PSA, and then also to see whether or not the ultrasound scores are decreased once they receive IL-23. I should mention that the patients in the placebo group at 6 months are then crossed over to receive guselkumab. So this study is well underway at multiple centers throughout the United States and Canada. So in conclusion, I've tried to give you some sense of how the complexity and heterogeneity of PSA can be leveraged to take a more personalized approach. But in order to do that, we really need to understand what's going on in the individual tissues. So in terms of diagnosis and management, this complexity and heterogeneity has to be comprehensively assessed. And we need to better understand the endotypes or the pathologic mechanisms driving the diseases in individual tissues, and then bring into the whole picture the treatable traits that we can work with patients to address so that their disease can be under better control. I've really reviewed extensively with you disease mechanisms, IL-23, 17, and TNF. I talked about CD8 T resident memory cells that are key long-term cells that may hold the clue to remission. And then both our humanized murine model of psoriasis and PSA, as well as our AMP-AIM project. Current therapies, which include IL-17, 23, and TNF antagonists, as well as apremilast, as well as newer agents that are in development, such as new JAK-STAT inhibitors, both oral and sub-Q, IL-17 A and F inhibitors, nanobodies, and then the IL-23 inhibitory peptides. I want to thank you for your attention and be very interested to address your questions in the next session. And lastly, I want to give credit to our research support, as well as members in my division and in the Center for Musculoskeletal Research, where we have our laboratory. Thank you for your attention.
All righty. Thank you, Dr. Ritchlin, for providing us with an amazing research update about psoriatic arthritis. We can't wait to see the results of your recent research activities. It's now time for our Q&A session. So our first question is, when I work with other people through our volunteer program, I come across a lot of hesitancy when it comes to injections and being on these biologics. People seem to be very reluctant to start them, which I completely understand. But I always try to reassure people that I'm working with my own personal experience. I've been on biologics since I was like 8 or 10 years old. What can you say to these patients that are reluctant, that haven't found relief with topicals or oral therapies? What can you say to them to kind of alleviate some of that anxiety or stress about starting a biologic?
I think the first thing, Avery, is to talk to them about the fact that psoriasis is not a disease just of the skin, and psoriatic arthritis is not a disease just of the joints, that there's systemic inflammation that can lead to problems in other organs, such as fatty liver, heart disease, atherosclerosis, type 2 diabetes. So it's important that that inflammatory burden is suppressed. And biologics are the most effective way to do that, number one. So the other area you want to address with patients is safety. That's what they're most concerned about, is right they should be. And
Right.
so what I do is to place the safety in perspectives that they can understand. So for example, let's say I'm talking about an anti-TNF agent. I say to the patient, if you're a patient with rheumatoid arthritis, and patients tend to be older and have more what we call comorbidities or other diseases, if they go on methotrexate over the course of a year, 3 out of 100 will develop a serious infection defined as either requirement for IV antibiotics or hospitalization, 3 out of 100. If you add an anti-TNF agent to the methotrexate, the number of patients who will develop a severe serious infection are anywhere from 3 out of 100, similar to methotrexate, or up to 6 out of 100. So the point here is those are numbers they can understand. So the likelihood of them getting a serious infection is between 3 and 6% in a year. And generally the patients get infections are those that are older and have more what we call diabetes or heart disease, kidney problems. So I think if we put it in clear language and telling the infection is the most significant, the most common side effect, and it's still very rare, then that helps alleviate some of their concerns.
Okay. What would you say throughout your research, the average time that people are on a biologic and then start to see their response waning?
Well, this is a big issue for us right now. As you're well aware, there's data saying that when patients are inadequate responders to an anti-TNF, for example, which is often where we start, that when you switch to another agent, that the likelihood of long-term response to that agent at 3 years is something like 17 to 20%. So this is why we're really working very hard to better understand these mechanisms. I would say that it's very individual how quickly a patient will respond, and it's very individual how quickly or slowly a patient will develop a flare.
Mm-hmm.
I think the thing that our approach we have a combined clinic, dermatology and rheumatology. We see the patients together with the dermatologist, is we try and do interventions that will keep them on their biologic. For example, if they're having a skin flare, we might use phototherapy, or we might use topicals, so that we can get them through the flare and they can continue the biologic that they're on. Now, sometimes you can't do that. If they have a terrible joint flare, the likelihood is you're going to have to switch to another agent. So it's highly variable. We need to better understand the mechanisms that underlie flare, and we're studying those in order to more effectively individually approach patients with these problems and with this disease activity.
Okay. Without obviously this being official medical advice or anything, for people out there that are experiencing flares here and there, what would you say? How long would a flare have to last for somebody to suggest switching a medication? You know, is it normal to have a flare here and there? You know, if you're I know I had a flare when I was studying for my board exam and stuff like that. Is that normal? Is that something that's cause for concern to maybe switch therapies, or you just kind of tackle it as it comes?
Well, flares are common in inflammatory arthritis, both rheumatoid and psoriatic arthritis, unfortunately, and psoriasis too. What I would say is that we want to know when patients are having flares. Very important that we're in the loop. And it really depends on the severity of the flare, the frequency of the flare, and whether there are other lifestyle changes that the patient can address. And in particular, ones that we stress are food choice, avoiding foods that are processed, minimal meat, and more of a plant-based diet, and exercise. And those are really very important features that can result in flare and in non-response to therapies. We know that now. It's really obviously addressing anxiety and depression are important, and also centralized pain or fibromyalgia, which may be confused with a flare, but you would not treat that the same way you might a flare of skin or joint disease.
Right. Okay. I know on several slides you mentioned lifestyle changes and diet and exercise. And I think it's hard for a lot of patients who first experience the arthritis at, maybe they're in their 20s or 30s, and it's just so bad from the start that they feel like they can't do anything. But I think for me, like getting over that hump was the biggest thing. And now it's like, if you don't move enough, then you're in worse pain than you are, if you are exercising every day. So I always try to encourage the people that I'm mentoring, like, I know you're in a lot of pain, but even just a short walk outside every day can help tremendously. So.
Absolutely. I mean, well said. We tell our patients, especially those that have more of a centralized pain component, that start off slowly. And we always say to them, you're going to be cursing me at the beginning because they're going to say, why are you making me do this?
Yep.
Pain is so much worse. This is not
Yeah.
good. And we say, persist, have the intention to keep doing this. And over time, this pain will be alleviated, and you'll be very glad that you either did a walk or got involved in a yoga class or did some cycling, whatever. I think it's really important to move. And once you get over that hump, as we describe it, I think that most patients are really glad that they've undertaken that approach, as you've outlined very nicely.
Absolutely. Are there any other ways to evaluate treatment response or systemic response to the biologics besides testing the inflammatory markers in our blood and just physical symptoms?
Yeah, so what you're alluding to is, do we have biomarkers of response outside of C-reactive protein sedimentation rate? No. This is a major gap in the field. And one of the goals that we have in AMP-AIM is not only to be able to say, okay, in the joint tissue of this patient, we see these pathways are being activated, but trying to find biomarkers in the blood that reflect what's going on in the tissue, so that we don't have to go do a synovial or skin biopsy in everybody to figure out what's going on. And so that's where our research is aligned right now, to really do serum analysis once we are be able to understand what's happening in the tissue. Very important question, but we're not there yet.
Okay. Because those inflammatory markers are non-specific, I guess. And, even if you have an illness or something like that, they can be elevated. And I always wonder, I feel good, my numbers look good. Does that mean my joints are doing good? It's hard to know. And it's kind of scary when you can't see or feel anything. So I guess you just, based on your physical symptoms, you just trust that the drugs are doing their job. And
well, generally, Avery, when we're talking at least about the biologics, a couple of points are important to underscore. Number one is, patients on the current biologics generally do not have X-ray progression. We know that. Okay. So even patients who might have a bit of a flare, the likelihood that it's causing damage to your joints is low if you're compliant with the medication. Secondly, if you are a patient who has no pain, no swelling, if you look at those patients in clinical trials, they do very well, extremely well. They're a group that we're not seeing not only X-ray progression, but if you look at the other measures of satisfaction, their sort of mental state and their social state definitely do very, very well. So I would say for someone like you, if you're feeling well, you're not having joint pain, your skin's controlled, the likelihood that you're having subclinical serious inflammation on biologic is very low, based on our experience.
And then I think this will probably be the last question, but is there, I think people that will be listening to this, including myself, involved in NPF, is there any way that any of us can get involved in your research in terms of being do you have to be on site, or is there any recommendations that you have for like finding local research in your area? Because I think we're all wanting to fight the good fight and contribute what we can. So do you have any recommendations for that?
Yeah, Avery, thanks for asking the question. Of course, as I mentioned, we have 4 patient research partners involved with AMP-AIM who are affiliated with the NPF, and they've been fabulous at helping us design our recruitment and thinking about what's important to patients, and an invaluable resource for us. So we're going to be putting on the NPF website the various sites that we have. You would need to go to a site. I can tell you they are UCSD, UCSF, Columbia in New York City, NYU in New York City, University of Alabama at Birmingham, University of Rochester, Northwestern University in Chicago, Hospitals for Special Surgery in New York. And all of those are centers where we are recruiting patients with psoriasis or psoriatic arthritis.
Okay.
And we'll get that up on the NPF website. So patients can approach us if they're interested, and they can go to their individual center and be enrolled. Obviously be screened and enrolled.
Right. Yeah, that's awesome. Okay, that's great to know. So thank you, Dr. Ritchlin, for taking the time to answer the questions we received and for giving such an informative presentation. On behalf of those with psoriatic arthritis, we appreciate all of the information you shared regarding current research activities and look forward to hearing the latest news regarding the progress of your work and others in this field.
Thank you, Avery. It's been a pleasure.
Thanks so much.
If you enjoyed today's webinar and would like to learn more about upcoming webinars or events, be sure to subscribe to receive notifications at psoriasis.org/subscribe. You can view this webinar along with past webinars in our Watch and Listen site at psoriasis.org/watch-and-listen. While there, listen to our podcast series, Sound Bites, to hear how psoriatic arthritis domains impact treatment choices with rheumatologist Dr. Arthur Kavanagh. And also you can learn more about the axial psoriatic arthritis with Dr. Atul Deodar in Psoriatic Arthritis and My Aching Back. If you have additional questions about psoriasis, psoriatic arthritis, and treatment options, contact our Patient Navigation Center by phone or email as indicated on the screen. Thank you for attending today's webinar. Please take the evaluation survey via a link you'll receive in the follow-up email after viewing today's webinar. Tell us what you think by providing feedback about the presentation and content. We'd love to hear how we can make our webinars better. We value and appreciate your comments. This concludes our presentation. Thanks again for joining us for today's webinar, a psoriatic arthritis research update, and thank you also to Avery and Dr. Ritchlin for such a wonderful presentation. This concludes our presentation. Thank you.